Welcome to our deep dive into dense deposit disease, also known as membranoproliferative glomerulonephritis type 2 or MPGN2. This rare kidney disorder can have serious consequences for kidney function. Join us as we explore its origins, mechanisms, diagnosis, treatment, and what the future holds for those affected. The exact cause of dense deposit disease remains somewhat mysterious, but it's heavily linked to dysregulation of the alternative complement pathway. Think of the complement system as the body's first line of defense against infection. In individuals with dense deposit disease, this system becomes overactive due to a complex interplay of genetic predisposition and acquired factors. The most notable culprit is an autoantibody called C3 nephritic factor, or C3-Nef. This antibody stabilizes C3 convertase, leading to its continuous activation and the overconsumption of C3, a key component of the complement system. In some cases, mutations in complement regulatory genes can also lead to this overactivation. This uncontrolled activation ultimately damages the kidneys. The pathophysiology of dense deposit disease centers around the uncontrolled activation of the alternative complement pathway. This activation leads to the accumulation of C3 breakdown products and other complement components within the glomeruli, the filtering units of the kidneys. Specifically, these deposits form electron-dense structures within the glomerular basement membrane, giving the disease its distinctive name. These deposits disrupt the normal structure and function of the glomeruli, leading to inflammation, scarring, and ultimately, kidney damage. The chronic inflammation damages podocytes, specialized cells essential for glomerular filtration. Over time, this damage reduces the kidney's ability to filter waste products from the blood, leading to kidney failure. Dense deposit disease is a rare condition, affecting an estimated 1 to 2 individuals per million. It most commonly presents in children and young adults, although it can occur at any age. There is no strong predilection for one gender over another. Due to its rarity and diagnostic challenges, the true prevalence may be underestimated. The signs and symptoms of dense deposit disease can vary considerably. Many individuals initially present with proteinuria, or protein in the urine, and hematuria, or blood in the urine. Edema, or swelling, particularly in the legs, ankles, and around the eyes, is also common due to fluid retention. As the disease progresses, individuals may experience hypertension or high blood pressure. Fatigue, decreased appetite, and nausea are common symptoms of kidney dysfunction. In severe cases, dense deposit disease can lead to kidney failure, requiring dialysis or kidney transplantation. Diagnosis of dense deposit disease typically involves a combination of clinical evaluation, laboratory tests, and kidney biopsy. Urinalysis will reveal proteinuria and hematuria. Blood tests will assess kidney function, complement levels, and the presence of C3 nephritic factor. A kidney biopsy is essential for definitive diagnosis. The biopsy sample is examined under a microscope, revealing the characteristic electron-dense deposits within the glomerular basement membrane. Immunofluorescence studies can also detect the presence of C3 deposits. While there aren't distinct subtypes of dense deposit disease in the traditional sense, it's important to understand that the underlying causes and genetic factors can vary. Some cases are associated with specific complement gene mutations, while others are linked to C3 nephritic factor. Identifying the specific underlying cause is crucial for tailoring treatment strategies. Treatment of dense deposit disease is challenging and focuses on managing symptoms, slowing disease progression, and preventing complications. Medications that suppress the immune system, such as corticosteroids and mycophenolate mofetil, are often used to reduce inflammation. Plasma exchange therapy may be used to remove C3 nephritic factor from the blood. AC inhibitors and ARBs are used to control blood pressure and reduce proteinuria. In cases of end-stage kidney failure, dialysis or kidney transplantation may be necessary. Eculizumab, a complement inhibitor, has shown promise in some patients, but its use is still being evaluated. More recently, targeted therapies focusing on specific complement components are under development. Currently, there are no established preventative measures for dense deposit disease, given the complex interplay of genetic and acquired factors involved in its development. However, early diagnosis and aggressive management of symptoms can help to slow disease progression and improve outcomes. Regular monitoring of kidney function and complement levels is crucial for individuals at risk. The prognosis for individuals with dense deposit disease varies. Many individuals experience progressive kidney damage leading to end-stage kidney failure within 10 to 20 years of diagnosis. Kidney transplantation is often necessary, but the disease can recur in the transplanted kidney. Recent research is focused on developing more targeted therapies that specifically address the underlying complement dysregulation. Clinical trials are exploring the use of novel complement inhibitors and gene therapies. These advances offer hope for improved outcomes and a better quality of life for those affected by dense deposit disease.